and evaluation component, which is unique among national nonprofits. Some of our programs, our capacity building programs that you may be familiar with today is our ASO CBO capacity building program that we offer around the country called Remaining Relevant and the New Reality, helping to support ASOs and CBOs in the changing landscape environment. We have capacity building services that we offer to health departments, workforce, offering that to providers around the country as well. A patient-centered HIV care model project, which is connecting patients to community pharmacists, care, and work with health centers as well. This program is being offered by our 3D HIV prevention program. The 3D program stands for Data and Delivery. Works with community members to facilitate community infrastructure development and systems coordination to ensure sustainability along the HIV care continuum. We promote workforce development, including training the next generation of leaders in HIV prevention, expand care team integration through partnership development to include non-clinical HIV prevention partners, develop cost effectiveness and outcomes monitoring of programs to maximize strength and efficiency and impact health outcomes, develop systems and retention and care to enhance health outcomes and coordination across the care continuum, and diversify funding of organizations to enhance sustainability. This is a part of our ASO Leadership Initiative program. We offer webinar series to individuals, provide a mentor-mentee program, and an online portal to ASOs and CBO leaders around the country. You can also become a certified ASO leader by participating in Health HIV's ASO Leadership Initiative. And we do have a program guide related to that leadership training and certificate program that you can download today. Also, in the lower right-hand corner of your screen, there's a little folder icon that you will see that is right down here in the corner of your screen that you can download today's webinars, recordings, as well as you download today's slide deck. The webinar recording at the conclusion of this webinar. Additionally, there is a chat box, and I see there's a lot of individuals who are currently chatting in the box. Feel free to write your chat messages in there, and we will get back to you as we move on to our next speaker. So we have a bunch of really great group of presenters on the call today for you, and I would like to introduce Reverend Lady Karan Sadler, a native of Nashville, Tennessee, earned her Bachelor's of Arts and Religion Theology from the American Baptist Theological College, and simultaneously pursuing studies in the MBA program at Tennessee State University. She is a graduate of Hood Theological Seminary in South North Carolina with a Master's of Divinity. For 3 years, she matriculated at Pfeiffer University, pursuing a second Master's in Marriage and Family Care Therapy. And during Lady Karan's internship with the Pfeiffer Institute, she provided intensive relational therapy to individuals, couples, and families. While living in North Carolina, she served as a chaplain at one of the nation's Leading Trauma Hospitals, where she provided support and counseling services, counseling serving the unequivocal needs of grieving individuals and their families. At this time, I would like to introduce Lady Karan.
Good afternoon. Thank you, Michael. Good afternoon to special thank you to our participants for joining us today. Discuss the women. Child fairness and HIV, violence, violence, are linked to complex blend of social, racial, and economic determinants. To reduce these health disparities, social determinants of health must be addressed. This is why we're having this webinar today. The focus will on African American or Black women who encounter several barriers. A few, we have skin issues, about HIV and STD transmission, other life impacts, also or not discussed at all. Our diverse and panelists will each share their perspectives, their experiences, best practices, and definitely thought-provoking ways to address HIV and the inequities of Black women. Our first speaker today is actually Dr. Chanel Frederick, who is a statistician in the Office of Minority Health, also known as OSH, and the Center for Medicare and Medicaid Services. In addition to providing leadership and direction to enhance Dr. Frederick is responsible for developing an agency-wide data collection infrastructure for minority health activities and initiatives, as well as developing and implementing reliable methods and strategies to merge survey data and utilization data. Recently, Dr. Wilson served as the Data Policy Office of Minority Health at the U.S. Department of Health and Human Services. This role is the coordination of OMH efforts to improve the availability and quality of national data to assess the health status for racial and ethnic minority populations. Dr. Wilson Frederick is a lieutenant mission corps of the U.S. Public Health Service. I introduce you Dr. Chanel Wilson Frederick.
Good afternoon, everyone, and thank you for that kind introduction. Today, my presentation will include an overview I don't see my slides.
Here they are.
Here we go. I hope everyone can see my slides. Today, my presentation will include an overview of the CMS Office of Minority Health. I'll also discuss Medicare eligibility and claims data, our recently released CMS Equity Plan for Medicare, and highlight one of the key priorities of that plan, expanding the collection, reporting, and analysis of standardized data, and also using the Mapping Medicare Disparities tool to examine health disparities in Black females. So, the Affordable Care Act requires the establishment of offices of minority health within 6 agencies and the U.S. Department of Health and Human Services. These offices join the existing HHS Office of Minority Health and the NIH, National Institute on Minority Health and Health Disparities, to lead and coordinate activities that improve the health of racial and ethnic minority populations. The CMS Office of Minority Health is responsible for coordinating minority health initiatives within CMS. We serve as the liaison between CMS, the HHS Office of Minority Health, and other agency OMH offices. Also, we participate in the development of CMS policies, regulations, plans, and programs to ensure that minority health interests are represented. And we also serve as resource to other CMS components. So who's eligible for Medicare? Well, persons who are age 65 and over are eligible for Medicare. Also those who are under the age of 65 but qualify
disease, or ESRD. CMS data are considered health services utilization data, also known as claims data, that are derived from the reimbursement information or the payment of bills. So what are some of the strengths of using claims data? Well, first is that claims data are clinically valid. They include admission and discharge dates, diagnoses, procedures, as well as courses of care. But in terms of health disparities research, claims data includes demographic data, such as race, ethnicity, age, place of residence, or date of death. Also, claims data can be linked to various other data sources, such as data from the U.S. Census Bureau or other providers such as the VA or Medicaid, as well as the National Death Index. So, last spring, 2005, the CMS Office of Minority Health released the first ever CMS equity plan for improving quality in Medicare. This plan focuses on reducing disparities in vulnerable populations and chronic diseases. This was the first time that CMS has ever released such a plan to address health equity in Medicare. This is a 4-year strategic plan which includes 6 priority areas and identifies multi-level solutions to reduce disparities in Medicare. The Mapping Medicare Disparities tool was actually one of the first products that were released from the CMS Equity Plan, and it was publicly available on the CMS Office of Minority Health website in March of 2016. The MMD tool is populated with aggregate county and state level data, 100% fee-for-service administrative claims data. The populations that are included in this tool include persons who are aged 65 years and older, those who are less than 65 with disabilities, and persons with end-stage renal disease. The MMD contains measures for disease prevalence, cost, and hospitalization for 18 specific chronic conditions, emergency department utilization, readmission rates, mortality, and preventable hospitalization. These measures can be viewed by race, ethnicity, and/or sex, using county and state level Federal Information Processing Standard codes, or FIPS codes. The next 6 figures examine chronic conditions among Black females who are dual and non-dually eligible for Medicare. This slide shows a national profile of depression among Black and white females who are dually eligible for both Medicare and Medicaid, also known as dual, as well as non-dual Medicare beneficiaries in 2014. The gray area on the map for Black females indicate insufficient data. The higher prevalence of depression is shown by the darker shade of blue on each map. Let's look more closely at Black-white disparities in depression at the county level among females in California. Figure 2, by hovering over Los Angeles County in California, a pop-up box appears showing the within-county Black-white disparity. The prevalence of depression in Black females is 6 percentage points higher than white females in Los Angeles County. Figure 3 shows the state-level prevalence of heart failure among Black female dual and non-dual Medicare beneficiaries. Remember, the darker shade of blue indicates the higher disease prevalence. For example, Louisiana is dark blue, meaning that Black females in Louisiana have a high prevalence of heart failure. However, let's investigate this further. As shown on figure 4, we can click on the download button, which is circled in red, and download the data to examine specific county-level prevalence estimates for all states. This table shows that Catahoula and Concordia counties in Louisiana have the highest prevalence of heart failure among Black female dual and non-dual Medicare beneficiaries in 2014. Additionally, you can then use your mouse and hover over each county in Louisiana. By doing this, it's revealed that Catalina and Concordia County are physically next to one another. So let's say you live in Pennsylvania and you're interested in knowing which Pennsylvania counties have the highest Black-white difference from the state average among females with heart failure. As shown in Figure 5, among female dual and non-dual Medicare beneficiaries, Armstrong County has the highest Black-white difference of 33% in 2014. On this next figure, we examine county-level Black-white differences in ED visits for female dual and non-dual beneficiaries with 3 or more chronic conditions. You see more darker shades of blue in California, in the South, and along the East Coast. The darker the blue, the greater rate of emergency room visits for Black females compared to white females. So in conclusion, the MMD tool can help to identify geographic disparities in chronic disease by sex, age, race, and ethnicity, and dual eligibility or single eligibility for Medicare. The MMD tool is an important step to inform policy decisions that advance health equity. The MMD tool can be easily found by Googling CMS MMD tool, and I provide a link to the tool on this website, on this slide with my contact information. Thank you. Thank you, Dr. Frederick. We appreciate your presentation, very informative. Our next speaker is going to be Dr. Sandy Gack, who is the co-founder who currently serves as the executive director, principal designator of the South Carolina HIV/AIDS Council, nonprofit HIV prevention organization, including the Black Prevention Center, the treatment facility located in South Carolina. She has committed the past 32 years of her professional life working in the area of human sexuality with a specific focus on HIV and STD, community-level mobilization, behavioral intervention, and research, technical assistance, capacity building, and elimination of other health disparities. I welcome
Good morning, or I should say good afternoon. Awesome. Okay, we're here. So let me just say that the South is a geographical area that, despite its attractions and our beaches and our Southern hospitality, we're continued to be plagued by our history. And it's our history of slavery and oppression that remains a hurdle, where the lack of public health concern and financial investment that would impact health disparities and slow down disease progression is seen too often by many political leaders as a consequence of behavior only versus the outcome or result of neglect. And so my goal, as we established our platform for today's conversation, is compelled to begin by confronting the elephant in the room. It was imperative for me that I look at my ultimate goal as a facilitator and ask myself what variables beyond behavior explain the continued prevalence of HIV among Black women in America. What is it that we're missing? What have we missed after 35 years of an epidemic? And how will we change our collective direction as we face turbulent political times and struggle to gain access to quality health care? And how will Black women and their caregivers and supporters take ownership to change our course? And so it's my intention to discuss historical factors that go unrecognized or unspoken, despite the fact that they are significantly impacting the sexual health and lives of Black women. I believe that these historic realities curtail our motivation and have created a sense of paralysis, resulting in our disproportionate overrepresentation in HIV. And so I am a recovering Northerner, originally from New Jersey, but I came to the South at the age of 17 to Tuskegee, and as a resident of a southern state since 1978, I have been enlightened. And now more than ever, I want to learn from the past and set my sights on changing the future by acknowledging the legacy and refusing to ignore the realities of slavery and how trauma persists even today in the hearts of Black women. And so the next slide speaks to the South as a historic legacy of disease where the health of men and female slaves were deemed unimportant or expendable. This slide depicts the realities of our passage and the historic dismantling of a people who once maintained and had traditions and a sense of ownership. Our transport here to the United States from Africa was filled with trauma, both societal, familial, and with a major impact on our sense of individual and collective community empowerment and community organization. We did not own our own bodies. Black women were property and were not permitted to have any control over their sexual health and well-being. The men were not permitted to protect their women, and like us, were forced to engage in sexual acts despite their consent or marital status. It was tradition to separate Black family units to create a sense of confusion and trauma, all for the purpose of generating wealth for the slave industry. On the State House grounds in South Carolina sits a statue of the father of modern gynecology, Dr. J. Marion Sims. His study of female reproductive systems included the development of surgical techniques which address severe complications of obstructed childbirth. Sims' use of enslaved African American women as experimental subjects is considered highly unethical in these days, and it serves as a foundation for why we are mandated to go through IRB mandates. From 1845 to 1849, he experimented on over 30 slaves, 3 mainly by the names of Arnica, Betsy, and Lucy. Arnica alone, over a 5-year period, endured 30 surgeries. And although anesthesia had just come out and was available, she was never offered the opportunity to have anesthesia. Many years later, despite what we reported in these experiments, in 1932, we were faced with the Tuskegee studies where over 600 Black men, over 50% of them with syphilis, were told that they had bad blood and were not offered proper treatment. What they were offered instead were free medical exams, free meals, and burial insurance. Although this experiment was only to take place over 6 months, it in fact lasted until 1972 or 40 years later. So where does this leave us? Clearly it says that we must promote now more than ever personal ownership of our bodies, regardless of age. What are we doing to engage in conversations and advocacy around reproductive rights, or are we being inactive and letting others speak out on our behalf? We must get involved in our schools and find out what our children are receiving and not receiving. The growing epidemic among young Black women is propelled by our nation's commitment to censor life-saving information within our public school systems. And I can personally attest that there has been a systematic intention to break down opportunities for children in the schools to get assistance. And so here we are with information that tells us that our children are not getting access to information. I don't know why these slides keep slipping back, but I'm trying to progress to factors contributing to HIV rates among girls. We conducted a qualitative and quantitative study a couple of years ago with girls 14 to 17, and I just want to note a couple of things in Robbing the Cradle, which was our attempt to look at the risk for teen girls as far as their knowledge and their sexual behavior, particularly those who reported dating older men. The outcomes of this analysis can be acquired from our agency if there are interests. But nevertheless, some key findings are listed on this slide, which includes that the likelihood of infection for a perceived main partner is the key issue. That self-reporting of an older male partner as a mate was significantly related to increasing or predicting the risk for a young adolescent girl's likelihood of infection. Reasons that potentially explain their lack of preparedness is provided in this slide. One important factor to note includes the ineffectiveness of short-term interventions or continuing to provide one-shot deals. It is imperative that Black women and systems of education stop censoring information under the premise that ignorance is bliss and that withholding information from our girls is somehow protective. This philosophy must extend to our families. It must extend to our faith-based institutions, and it must extend to other African-American community systems. The data that you see before you is the result of some of the studies of Dr. Gail Wyatt, who is a renowned psychiatrist and expert in sexual health. You will see findings from some of her work that clearly speak to why we are at higher risk. Black women are still functioning under a standard that was based on our history of Africanism, who, when we had strength in our unions, that was destroyed through slavery. So many Black women will never marry. Many Black women will have difficulty for a host of reasons finding a steady mate. How will we prepare our girls to navigate in a world where they may never find a lifetime partner? So the coordinated efforts must include knowledge, acknowledgement of sexual trauma among our girls. Confronting this means our active engagement in addressing the truth and the impact that our girls have faced through unrequested and coerced acts of sex within and throughout our community. And because, quite frankly, I don't see the difference in our censorship than the acts of violation that have occurred historically in the past. The Black community must stop covering it up, blaming our failed marriages, allowing our daughters to be subjected. We must protect them at all costs. And so the role of Black women within the faith-based community is documented. The question is, do we practice what we preach? Are we promoting sex role stereotypes, sexual stigma? And are we creating firewalls that prevent our Black girls from accessing knowledge and accessing health services that they need so desperately? So Black women must confront and combat misinformation. We must combat apathy. Front and combat misinformation. We must combat apathy. We can no longer be Black women in America who are uninterested, complacent, and believing that our education, our social status, or our economic solvency means that we are not at risk. We must combat intolerance. We must speak it when we see it. We have Black women who love other Black women, who remain at risk for HIV as well, and we are uneducated about our community of gay sisters. Then we must educate ourselves and lend our voices to change. The truth is that we can't save souls if we can't save a life. So before you, you'll see just mere examples of national organizations that are led and created by African American women. We must place this issue on our national agendas. This is bigger than one observance. It is bigger than once a year at the State House. It is bigger than a photo op. Our efforts must be coordinated, high priority, and funded at some level to ensure the agenda has power. As we all know, people judge the value of something based on what we invest in, both monetarily and the amount of time we are willing to devote to it. Put our money where our mouth is. Positive Voices is an example of HIV positive women who are ready, willing, and able to step forward and speak out. They are looking at core competencies, skills, and attributes that they must use to advocate for themselves. We black women have spent so much time taking care of everybody else. It is my proclamation that it's time to take care of ourselves. So we must mobilize our efforts among non-traditional women's groups, calling all black sororities, Eastern Stars, Links, Jack and Jills, and all others to the floor, even the legislative floor, to lift our voices about the impact of HIV. Because if we change nothing, nothing will change.
Great presentation, Dr. That is very powerful, very informative, and I think this definitely charges us to action and causes us to again have a different lens to look at HIV as it relates to women and girls through a different lens to create change. Our next speaker is going to be Dejan Dixon Jarrell. And she did a good job, but I think she should be back on the call. So let me share a little bit about Dejan with you. Dejan is recognized as a visionary and advocate in the struggle for women's human rights and reproductive justice, and the fight against HIV and AIDS on behalf of communities of women living with HIV and those at risk for HIV and STD. Dejan is the founder and president of Continuum Incorporated, established in 1989. First women's HIV/AIDS and RJ organization in the southeastern United States. She is a proud member of In Our Own Good, National Black Women's Reproductive Justice Agenda, where she advocates for sexual and reproductive justice in public health and prevention policies and programs. In 2001, Dejan opened a sister program office in rural South Africa, in Johannesburg, where the project focuses on capacity building and sustainable development for local women-led HIV/AIDS organizations. I present to you Dejan. Dejan, are you with us? And I don't think she is. So as she is transitioning, I just to let you know, Dejan is actually calling us from Johannesburg. She's at a conference there, and her system is a little slow. So as a transition, we're going to transition briefly to our next guest panelist until Dejan's able to join us. Our next guest is actually Frances Ash Goins, who is a public health expert, health administrator, policy analyst, health educator, and registered nurse. She is the clinic relations manager for the New Morning Foundation South Carolina Contraceptive Initiative. Formerly, she was the deputy director and acting director for the UNCHS Office of Women's Health, where she was responsible for the development, initiation, and implementation of OWA, which is the Office of Women's Health programs, and policies in partnership with other federal agencies, national and local health organizations, and leaders committed to advance women's health with specific concentration on lupus, HIV and AIDS, violence against women, diabetes, organ tissues, donations, kidney disease, health promotion, and disease prevention for women and girls. I want to introduce you to Frances and Frances speaking. We'll begin from Dejan. Frances?
Hello, I'm here. Can you hear me? Hello, I'm here. Can you hear me? Great. I heard somebody. Yes, you can hear me now? Hello, I'm still talking. Can you hear me? I'm on the phone. Can you hear me? Oh, great. Thank you very much. I am thrilled to be on this call. I don't have any PowerPoint presentations because I want to speak to your heart, to your thoughts, and just on some reflections. I have been involved in HIV since, I guess, 1983 when I was in Berlin, Germany. And then I came to Washington, D.C. Worked on I guess with Howard University with the AIDS program, I worked with the White House Office on AIDS, the Office of National AIDS Policy, the Office of Women's Health. And do you know that through all of that, I thought we were doing really, really good work. In fact, we were. The biggest thing that has happened is that I have, after 20 years working with the federal government, I have moved back home to Columbia, South Carolina. And that has been quite a reflection for me. As I've gone around the country with my new organization around the state, not the country, you know, it's amazing that I see people across the state, and I'm talking to them about reproductive rights, which has a lot to do with HIV. But what I hear is
Hold on 1 second.
that, okay, great.
Are you there with us?
They say that HIV is not so bad. They just take drugs. The connection between reproductive health, contraception, sexually transmitted disease, HIV is non-existent in people's minds. They're all separate things. Many people that I talk to talk about it's God's will to have babies, so it's okay. But there's no regard for transmission of HIV and STD as a factor in getting that baby. Some girls are told when they're pregnant in school that they have to go to online school and just stay at home. Some girls say that their goal is to have children because they have family support, and it's a good thing. You know, it's amazing to me as I've been in certain rural counties in South Carolina where a lot of the young people say, we have nothing else to do. What does that mean? That means that there are limited sources of activities for youth, and therefore going from house to house, having babies, talking to other kids about having babies is the thing to do. They also talk about how cute the boy is. And, you know, it's interesting that the cuter the boy is, the more chances he'll have more sexual partners. So what do you do? What do you do in that? The messages are important, but many of the health coalitions in South Carolina are dealing with the major killers of African Americans. That is heart disease, diabetes, dealing with obesity and the complications, and they don't even think about HIV/AIDS. It's way down on the list. How do you talk about love in relationship to keeping yourself safe from HIV and STD? That conversation, as Bambi talked about early, is just non-existent. With all of our knowledge about HIV/AIDS and STD, I found out that everybody is not on the same page that I'm on. Since I've been back home in South Carolina, I would love for all the organizations that work on the other conditions, say heart disease, to recognize that with HIV/AIDS, people don't live long enough to get heart disease. Many of our politicians in South Carolina legislature are also pastors of churches.
Can you hear me?
And I do believe
I think one of the conversations that needs to be expanded, let's talk about pre-infection, is how, you know, much of the conversation around pre-exposure prophylactics or PrEP has been focused on MSM, young gay men of color, young gay men. However, I think that there is a broader conversation that really, given the fact that people are transitional in how they relate on an intimate basis, that which would also include male and females who may not be at a place where they're totally open about the numbers or extent of intimacy with same-sex partners. You know, this conversation about PrEP has to be broader than just gay men. It has to, if we have a heterosexual couple where one of the partners, say, has another risk behavior, in this case, example might be IVDU or injecting drug use. Certainly the partner of that relationship who is HIV negative and who is not engaging in IV drug use is clearly a candidate for PrEP if they are choosing to maintain that relationship. And so there's a host of things. I'm a person about prevention. One of the barriers that we have in the way we have framed HIV is that we have focused so much on gay community that the heterosexual community thinks we're not talking to them. And part of engaging Black women organizations and even African American male-centered organizations, why that's so important is that we have to get out of this stigma that we've created in our community by just talking about the epidemic among gay men of color and making it very clear that this is a community issue, both a white issue, but it is also a Black community issue that ranges beyond just orientation. And so there are some interventions. I don't know how we get that communicated to the listening audience, but I know that, like robbing the cradle data and any other conversations around transitioning this dialogue into heterosexual relationships, I know I'd be happy to have a conversation and share whatever I have from an intervention perspective for that person who asked that question. I can put my number up there if needed.
Sure, we can text that number to you. We can put that number out to that particular individual.
Okay.
As well for you. The number that you have provided me today.
Oh, okay, that's fine.
Is that correct?
Yeah, that's fine. You can do that. I'll also type in my office number on the talk line. Okay.
We do have Daison back on, but we are not able to activate her audio due to the technical, the distance, I believe, that we have happening. Currently. Also, just to let individuals know, in the chat box that you have on the right, we have a number of individuals that have put forward a number of CDC resources on geographic HIV data and maps and some links for some individuals. I do have another question that has appeared. I have worked primarily with MSM concerning PrEP, but I do not hear much information about PrEP in heterosexual relationships. Does someone want to take that question?
Well, I think that's what I was alluding to earlier. One of the things that we're doing here, fortunately through support from Gilead, is that we are moving forward in PrEP education and PrEP community forums. The truth is that you know, it's like anything else. Number one, we have providers that haven't bought into PrEP, which is a whole nother challenge that we'll face. But at the core of it, if we want to engage heterosexual couples and communities around PrEP, we have to use our resources, our educational expertise to get out here in the community and make them aware that PrEP exists. Since that technology came out, there's nowhere that I go. There's no panel that I sit on. There's no legislator that I engage that I do not put in their hands information on PrEP. And so there's some groundwork that's going to have to be completed by our community of service providers to educate communities so that they start asking their physicians about PrEP. That will not address, however, the level of unpreparedness, if you will, of the medical field, the attitudes that still exist in the medical provider's mind around PrEP, including the stigma attached to it. So let me just say, we're at the beginnings of this innovation, despite the fact it's been out on the market for a number of years. But as it relates to community awareness, we're at the very beginnings, and all we can do is continue to push, provide information, mobilize communities, and use every opportunity we can. From a relationship level, we need to incorporate this conversation into our counseling and testing, and work out a strategy to integrate and refer people who we know fit the risk factors so that we can get them evaluated to see what their capacity is to access themselves to PrEP.
Hi, everybody. Yay! I am back on audio, but I still can't see a darn thing off the screen.
Okay.
I'm still loading slide number 30 out of the whole bit. So I'm sorry I missed so much, but I'm here.
Great. Jason, do you have access to your slide set, and we can advance the slides as we go along?
I do.
Well, we would be happy to do that for you.
Okay, well, it's going to be just a little awkward because I won't be able to, well, anyway, all right. So, yeah, let's just go. And I'm not sure where I stepped in. It sounds like there was really good questions and conversation going on PrEP, and hopefully we can come back to that. Touch a tiny, not very much on it. Hello, everyone. I'm Davon, and it's evening time on this end, almost 7 p.m. So good afternoon and good evening wherever you are listening to our webinar this afternoon. And so I'm really, really grateful. Chantel was fantastic in giving us some really good immediate tools and how-tos. And Sandy, thank you so much for giving us our San Coco moment, which is a really powerful opportunity to remind ourselves and to learn new or learn anew where we've come from in terms of where we are and what we have to recall and retain in order to go forward in reproductive health and well-being. And so I'm going to expand on that just a little bit more and plan. I'm really, really sorry if I missed your prior comment, but I'll have to go back and listen to the webinar later. So my aspiration of this conversation with you is to expand a little bit, I think, on what Dr. Hammond was talking about, but also put it in the context or in the larger context of looking at data care, and also within the realm of how we look at HIV. And so you know this data, but it's encompassed for me, and I shouldn't say next slide when I advance, but it's incumbent upon me, as it has been with Bambi and Plan, to really recognize and acknowledge that despite the gains made in terms of the reduction of new HIV infections in the United States, but that the rate of diagnosis in women and girls, while slowing, is still not slowing at the rate that it needs to, and it's certainly not happening at the rate that we need to in the South. And so in the southern region of the United States, as well as in Puerto Rico and the U.S. Virgin Islands, as a part of the territories, women of African descent are still hit hardest in our region, in our country, and in our territories as well. So when we're talking about prevention we'll talk about identifying HIV and what the first stage of how we get access to services and care. It really begins with understanding the care continuum, or what's also known as treatment testing among women. And this is a little dated now, but not so far behind in terms of 2012, where women still fall below the national, what's known as the national average access to care, which has many, many purposes. So for the next few minutes, I really want to focus on what's most important, and that is actually getting tested and linked to some sort of care. And at this point, testing and linkage to care for all is the description of the day, and that means regardless of the HIV test result, that especially for women and young women, that there's a link to a next service with regard to their HIV outcome. So let's talk a little bit about what this testing issue means, especially for women next time. There are key questions to engage in understanding. There are key questions to engage in understanding what we mean when we talk about limited testing. For example, we still know that at least 15% of women who are living with HIV go undiagnosed, and that means but we have to be able to understand who we're talking about and who's half of the new infections are among women under age 35, and 84% of infections are women nowadays have infection sexual contact. Most women living with HIV rely on the public health sector, whereas most women rely on the private sector. So women-reported testing overall has increased, but in the last couple of years, that testing has been checked. And I would like to say that probably some of that is just the increased attention as worthy and as warranted in regards to getting a fix with this. Color black and brown, but that is so much of the message to go out to those not good, but it's important to note that as necessary, there's the access. And that's also, I think, a telltale sign of family with the breast access. And while more than 50% of women are tested, that pattern is also stagnant. So who is getting tested? Black women and Latinas are more likely to report testing. Testing is highest among women under the age of 35, and it's also highest among women who are reporting public insurance coverage, typically known as Medicaid or state-level health insurance. And it's important to acknowledge that it is something that still is probably done elsewhere. There is not really so testing higher among women reporting more opposite sex in the past year, and that women who test by the risk categories that are identified are majority transactional sex, some also in commercial sex work, and having sex with non-sexual men. Most women get tested as part of their prenatal care and are tested as part of another health visit, so most had to ask in the first place. And we have lots of challenges and missed opportunities, including 4 in 10 women testing positive had never been tested before. Understanding that if they haven't been tested, it's also a risk of passing HIV on to children, pregnancy or at birth, and in breastfeeding, and also passing on to partners. At birth, and in breastfeeding, and also passing on to partners. 1/3 of women are diagnosed late, and more than 2/3 were not asked by their doctors to test. So we've got lots of barriers to women getting tested, and most of them are structural. Many folks who are undiagnosed don't access health care until they are pregnant or experience some stigma issues with that. And then, of course, put our family, work, and community responsibilities above ourselves and our health. And there's not enough research on how to best treat women at risk, and especially those who are undiagnosed with HIV. It's finding women where they are is still our largest challenge. So if I could advance the slide, the care continuum for prevention some of these critical issues as well. I would mention that the family planning clinic, women's health clinic, mental health services, where women go, saying that the family planning facility under regulatory care, yet we know that still, even as of 2015, not that many family planning Title 10 clinics have yet integrated HIV testing here. So next slide, when we talk about care, my own elementary model of what we call a community-based double healing, which is a care continuum for prevention and treatment. That initial circle that requires an individual and community investment as well in terms of delivery, service information about what services are available, as well as basic information about HIV infected and what the new modalities prevention and the treatment are today. Innovation and intervention are still critical, both structural and behavioral, as well as social. Community-based research is an ongoing need, as well as community engagement and mobilization in educating our communities and ensuring people know what services are available. But this one, I'm sorry to back up, the community-based double healing, if you look at that top line, from an HIV positive test result, we know what that line of activity, we know it is a cascade. People should be linked to care when they have the opportunity to engage in care and be seen for clinical services, counseling, support services, ancillary and facilitating services, helping stay engaged. And another big treatment, ensuring that they have the funding for that treatment and all of the resources necessary to remain adherent to its myelosuppression. But if a person is HIV negative, there's a different pathway that is fluid and that is continual and that is cyclical. So a person who is negative advantages before they need to be screened and they need to care for other high impact prevention activities, maybe behavioral activities, maybe additional prevention interventions around violence, around housing, around jobs, around education, and around community support. So it also might be something in terms of linking to high impact prevention interventions directed about sexual health, transmitted diseases, accessing PrEP and or PEP, and remaining HIV negative by consistent testing. So these are many different factors that impact that continuum. And if I went forward from the social barriers, stigma, the provider-patient interaction, and the trauma and violence, it still comes to the end of the day that as we're linking, engaging, treating, and supporting women, and this is a global stat, 27% of pregnant women with HIV will not receive antiretroviral for prevention of mother and child. And I highlight this so it's a global to let you all know that just as recently, even as a month ago, our own state data in the state of Georgia reported that we had 32 perinatal transmissions in the state of Georgia in the last 4 years, and all of them African. So what does this mean? And I'm going to go through this available on the slide and on the webinar later. But what does this mean in terms of women actually getting the care that's needed in a structural environment in which we are just fighting for Black lives matter? So the dangers and infections around HIV sexual and reproductive justice were very different because of the rate of infections with HIV among women of African descent. And we looked at it and laid out most poignantly, not only particularly that sexual and reproductive infection, that there's control of exploitation of girls and individuals, our bodies, our sexuality, our labor, and our reproduction. And so the response to sexual and reproductive infection must be justice. our human rights and dignity, but it does indicate that it's a triple combination of reproductive health in the way of services, of reproductive rights in the way of legal advocacy, and reproductive justice in the way of movement building are the ultimate triumvirate in reproductive oppression. Next slide. And so it suffices for us to locate critical issues about human growth in the Black community and HIV/AIDS and the framework for sexual and reproductive justice. Right. Next slide. There are specific challenges for women in particular around HIV and reproductive justice, a lack of HIV information testing and care, discrimination, bias, and stigma in the healthcare setting has not been found, disclosure issues with how people are treated, provider bias, positive and sexuality and expression, so that leads to sex negativity, negative bias towards women with HIV in terms of their own sexual expression and sexuality. Informed consent is not necessarily upheld. Family planning options are limited. Fertility options HIV. Insufficient provider expertise and inadequate research, as well as discrimination in courts. So there's more that can be shared. I think one quote from a Washington Network USA Human Rights Survey that was conducted several years ago, when a woman said, quote, "I was told by several doctors to abort my pregnancy. I was almost in my second trimester before I knew I was pregnant. I ran out of many a doctor's offices and years after being told that I was healthy. Or, if that was my life, I could have an abortion." The sexual coercion as well as coercion to abort or forced sterilization on women with HIV are clear. Another dangerous intersection is the intersection of HIV and trauma and violence. Next slide, please. HIV and violence undermine the successful risk reduction that we are all trying to reach. Measures of incidence reduction among women of African descent. Violence puts women at greater risk of HIV and other STIs. It compromises successful partner and obviously exposure for women. The perpetrator is given greater, and this is data, the perpetrator is given greater STI and HIV behaviors and infection, as well as the fact is that women with HIV suffer PTSD and intimate partner violence way above the national average. So the experience of lives that shows you that the difference between women living with HIV among all other women in the United States in terms of partner violence, at which women with HIV experience 5.5 out of 10, more than half, women living with HIV some form of violence, partner violence, sexual violence. And the fact of the matter is that there are barriers all the way around well-being when violence and trauma are introduced, especially in the realm of HIV, and that it also compromises immune function for women at greater risk as well as women with HIV. Increased prevalence of stress and depression and chronic anxiety, blood counts, and other biomarkers of disease. There are associations that also cells and red blood cells and cell function. There are all kinds of neuropsychological functioning that can negatively impact responses to other infections as well. And so, what's important is that stories of women living with HIV are critical. Because trauma impacts everyone, including post-operative medication. It helps focus on the treatment that may more or better by first working through trauma and stigma. That the risk of higher costs for women living with HIV as well as registered violence. And beyond treatment, trauma-informed care is also a critical part of our HIV and counseling. So, positive women have been implement advocacy, and where they implement advocacy, we are able to impact things like the National HIV Strategy, the High Impact Prevention Program, and the Affordable Care Implementation repressed and post-exposure prophylaxis in non-hospital clinical settings. Greater integration of HIV infection and sexual health services, especially health understanding planning and are an ongoing cry of women with HIV. Criminalization of sex workers, protecting, preventing, and securing women and youth access to contraception, family planning, and abortion services, and of course, ending HIV criminalization once and for all, are all critical points of action that help us address the sexual and reproductive oppression that continues to drive HIV. In 10 specific age groups among Black women, women under 35 and women over 55. With additional sexual and reproductive health issues that accompany both of these age groups are words of our example. So that's again, I apologize for the waiting for the technical challenges, and I'm delighted to have an opportunity to share this conversation.
Thank you, Dana. I just wanted to see if Francis was active on the line. I apologize to folks who are out there today. I know that some people heard Francis speaking. We did not. I do apologize for that interaction or the lack of interaction there. I did have, I know that in our chat box we've had some really great resources that were provided to individuals that we will be happy to post as well with the PowerPoint and the recording, which will be on later today. And I know that there was one additional question that I saw here that I wanted to pose to the group. Any women of color in faith groups have not been talking about issues such as HIV and sexual health. Have you found successful strategies for promoting this dialogue?
Michael?
Yes.
Yeah, this is Bambi. And I noted in my notes that we have a number of published articles on Project Faith, which was Fostering AIDS Initiatives That Heal, which was a legislative program funded from 2006 to 2011. So that I would be happy to share PDF versions of those articles. To the question, one of the things that we sought to do was, and our philosophy was, we're looking for a few good Marines. We didn't care whether those Marines were male or female. But we sought churches and we were directly funding faith-based institutions. And one of the criterion was that, one, if they had a pre-existing health ministry, which is usually run by women, if they had a nurses guild or some other structured committee or group within their faith-based institution that dealt with health, that was the group that we approached. A part of engaging women and even the clergy or the leadership is, it's not so much that they don't want to do it, they don't know what to do. And so part of it is not necessarily going to the pastor, but it's going to women in leadership in the faith-based setting, or going to men in leadership to get them to let you in to present your platform of information. You will have to make some concessions on what they can deal with initially, but I'll go back to what I said earlier. One, you can't save a soul if you can't save their life. And so look for those faith-based institutions that have a clue, that want to do something, that want to be a part of change. Do not waste your time trying to convince people who are more interested in giving you reasons why they won't do it than reasons why they should. It's a waste of time. Focus your attention on movers and shakers and innovators who are within those faith communities, people of social capital that have an ear to the clergy and leadership, and focus your attention on those individuals, particularly the pastor's wife.
Hi, this is Francis. Can you hear me?
Yeah, maybe I need to know. I would add that it is also important to create faith-centered spaces away from the institution. In other words, inside churches, as Andy was saying, is one thing, or churches, synagogues, and mosques. But when we hold community events that are also faith-based or at least faith-inclusive, then we tend to get engagement from those church folks, women in particular, in ways that they would not engage to have it on the grounds of their pastor's home base. And so I would say don't be afraid to invite people into spaces that you create with faith inclusion, as opposed to trying to break in doors that have been shut for 35 years.
Preach!
Do we have Francis on board with us?
Can you hear me? I'm here. Can you hear me?
Okay. All right. I thought she had come on board with us. Karan,
I am.
Any more questions in the box at this point? Do you have any closing thoughts for us?
Thank you, Michael. I just want to say thank you to the panelists. As you all have heard, this is a very knowledgeable group of individuals that are committed and very passionate about the work around HIV and specifically even around the work around women and equity and the disparities that are associated with the African American community. So I just want to thank the panelists for really being patient with us today and for providing us with such plethora of information that I think will be very beneficial to all of us. Heard, and even as we go back and listen to the recording, I just encourage the listeners to really go back and listen to the recording and really begin to create significant institutional changes in your communities. One last thing I do want to add to the question regarding the basic community. I encourage those to go visit the NAACP website, that's NAACP.org website. They have a toolkit that is available that provides guidance around HIV and advocacy and engaging the faith community. And I do echo Dr. Dennis's response regarding how you invest your time and how you invest your energy. It's important to identify those individuals that are doing work or who are even interested in doing work around HIV. Because there are so many faith leaders who are still struggling with the myths that they consider to be facts. So I do want you to also though consider, don't give up on them that may not be doing anything because they just need to be educated and they educated and they need to understand how the Black community is being disproportionately impacted, and we are able to reach and raise that awareness of more individuals we can have tested, and not only have tested, but we can get them into care. So that's very, very important as well. So don't give up. This is around for a long time. This movement has not yet begun. It has been going along for a long time. We have a long way to go. But because of individuals like yourself, we can create change and continue to hopefully have less new infections. So continue to fight, and thank you to Help HIV and to all the panelists for this opportunity.
Great. Thank you very much, Karan, for helping us organize this presentation. I'd like to also echo my thanks to all the presenters and again apologize for the technical challenges that we've had during this webinar, and apologize to Francis, who some of you may have heard and others were not able to hear, including us. So I do apologize to that. Just keeping in mind on your screen, in the bottom of your screen where the arrow just went, there is a little folder icon where you can download to today's PDF of the PowerPoint slides that will be available. Also, at the conclusion of this webinar, you will receive a survey to rate the presentation today for us. We will have available the webinar will be on our website shortly for individuals to access the recording of that. And at this time, I would like to thank everyone for participating. And if you request additional capacity building services from Health HIV, please feel free to reach out to us. Again, my name is Michael Schenkel, the Director of Capacity Building, and Marissa Tonelli, the Senior Capacity Building Manager with Health HIV. At this point, we will conclude today's webinar, and thank you all so very much for your participation.